we will talk about magic external fixator and its benefit for correction of deformity of the foot, especially club foot, Queen of Halibis. Particular qualities of foot correction deformity using the Ilizarov external fixator. The best treatment of many challenges orthopedic problems is still unknown. Wisdom: if you cannot help the child, leave him alone until other one get it. The question is, why Ilizarov? Ilizarov system contains of Ilizarov's external fixator and the Ilizarov principle. The law of tension stress is the origin law of Ilizarov technique. It's a gradual traction on living tissues create stresses that can stimulate and maintain the regeneration of active growth of certain tissues. The Ilizarov techniques allow new histogenesis of soft tissue as well as bone. This process allowed correction of complex three-dimensional deformity. There are three main types of foot deformity: equinovarus, calcaneus valgus, metatarsal varus, or adductus. Here, most of common deformity of foot. The main etiologic factors. We are talking about old deformity, not young as before Dr. Abdullah Nassar. Neglected and relapsed club foot, which treated bad before. Burn contracture, poliomyelitis, after trauma, after gunshot injury, meningitis, leg length discrepancy. The treatment, the best treatment at the childhood. The bone city method is now the accepted method for treating clubfoot deformity in a newborn. Unfortunately, this method has only recently been adopted as the standard treatment of clubfoot, and there are many drawbacks to using conventional approach to the treatment of complex deformity, like the increased risk of neurovascular injury, soft tissue injury, and shortening of the foot. An alternative approach that can eliminate this problem is the Ilizarov method. The Ilizarov technique involves placing tension wires through the bony structure of the clubfoot to realign joint surface and foot deformity. Preoperative evaluation. Range of motion measurements, standing footprint, two plane and posterior tangential radiographs, computed tomograph and 3D reconstruction, photography. The talus first metatarsal angle, calcaneal pitch angle were measured on lateral weight-bearing film, plantar sensation, neurovascular assessment, Doppler ultrasonography, especially in a case of burn contracture and previous surgical intervention for vascular evaluation. Technique. Many authors recommend a non-osteotomy technique for patients who had a congruous joint with no significant fixed bony deformities, and for children younger than 8 years. Ilizarov device consists of two range proximal and distal support applying to the leg and directly connected by connective elements with each other, and with half or square range horizontal support and sometimes full range if foot is small at calcaneus bone, and vertical half range support at metatarsal bones applied to the anterior foot. The vertical half range and the horizontal half one can move with respect to each other and with respect to the device based on the leg. We use tensional wire from 1.6 up to 2.5 millimeter. Must be inserted at the beginning into the tibia for two bases range and for metatarsals and for calcaneum, and connected the range using rods, bolts, plates, and hinge joints links. Destruction start on day 3 using calcaneum metatarsal and tibia calcaneal rods at a rate of 1 millimeter every 12 hours medially, and 1 millimeter every 24 hours laterally. Because the shortening at medially more than laterally. The frame correct to achieve maximally correctable position for the foot needed. The amount of destruction was assessed clinically by the amount of pain and capillary refill. Destruction can be reversed at time of the anticipated problem and started again after a few days. If we see the change of color or temperature of the toes or foot, we stop and draw back. After a few days, 5 days, 1 week, again. This we see at the left side, 2 basis range, what we talk about. And at right side, 1 range at basis with the boots. Boots compensate the other range in slim patient or in child patient. And the horizontal half range or square sometimes with it, if possible, because the elements of Ilizarov high costed and not all we can get. And the vertical half range at metatarsal bone. All connected by rods and hinges, sometimes by plate with hinges, depend what you have. This application, but with other instruments, but the same principle. This also, but the same principle. This video will show you simply how to do. But this modern external fixator calls a Tyler special frame. Now we are working at this range. لا لا بس مع الفرحات. Ilizarov technique for residual idiopathic or neurogenic clubfoot, the treatment achieved by supramalleolar or V or U shape osteotomy via the calcaneus and talus bones, followed by gradual destruction of soft tissue and bone and forefoot reconstruction. After complete correction, the foot was maintained in the assembly in a static position for 3 up to 6 weeks, depending on the case. Then the assembly was removed and an above knee cast applied for 6 weeks. If patient can patient the fixator, we didn't use the gyps and we keep it 6 weeks more. This is U-shape osteotomy through the talus and calcaneus bone by the lateral incision, of course. This V-shape osteotomy. Here Ilizarov construction with U-shape osteotomy. This is before correction and after correction. This illustrates simple illustration to show you the V osteotomy. and after reduction, what going with bones. This different montage of Ilizarov, but the same principle. We did more than 50 cases, but our study 36 cases, period 1999 up to 2018. Patient and method between 1999 and 2018. 36 patients with deformed feet were treated using the Ilizarov method. The mean age was 17 years. They range from 8 up to 40 years. 25 of the patients had undergone stabilizing procedure of the foot. 21 tribal arthritis, 4 ankle arthritis. For 5 patients was done tibial osteotomy for lengthening and deformity correction. And for 5 patients performed only a soft tissue release. The etiologic factor: 3 burn contracture, 11 polymyelitis, 15 neglected and relapsed clubfoot, 4 trauma, 2 gunshot injury, 1 case post-childhood Madura foot. The mean duration of fixator application was 5 months. Here, distribution of the type of operation, we see most of operated patients were tribal arthritis and less ankle arthritis. Here, the distribution of etiologic factor, we see here the most of them neglected and relapsed clubfoot. That's why if we used bone city method, we will remove all this percentage. First case, girl about 20 years old with childhood Madura foot. There is a quinovarum deformity, rigid. We did for her tribal arthritis and Ilizarov fixator. Here, after operation 1 week, she walk. Not all patients walking because of the pain, and they didn't want, but we permit them to walk. This patient, after a road traffic accident, treated by external fixator and gyps, but no improved. We did for him realignment of the fracture and gradually correction of Queen's deformity. Thereafter, 6 months, good healing. Here, good shape of the foot and leg after removal of the external fixators. This patient, after boy, 15 years after trauma, by their word, in the childhood, with completely rotation of the foot externally and ankylosing of ankle joint with shortening of the leg. We did for him supramalleolar osteotomy, correction of the foot, and proximal tibial osteotomy for lengthening. This before, after operation, lengthening, now good alignment, good length. This patient, after road traffic accident, 20 years old, treated by external fixator in other place, and we did for him shortening at the fracture comminuted at distal leg, and we get coenus correction directly because of the shortening, and we did osteotomy, proximal osteotomy for tibia for lengthening. This neglected clubfoot, child 9 years old, we did for him soft tissue release and applying Ilizarov fixators. After 3 months, we removed. This is the same child, by the same child at all, but by the cause of this deformity, by their word, they told he has a childhood injection, and after that, the deformity growth. I don't know if this is true or not, but he has also shortening of the leg. We did the same application. Good correction. This post-trauma patient, road traffic accident, 30 years old, and bad corrected. Break now, no problem. We did for him correction and the Ilizarov fixator. This after reduction. This neglected clapboard, the same. This patient after childhood burn with completely rotated externally about 100 degree, more than 100 degree external foot with ankle uncross and shortening of the leg. I don't know how can correlate between burn and the shortening of the leg, but their word. We did extragallectomy, removal of talus, and the adaptation between leg and calcaneus, between tibia and calcaneus, and get acceptable foot. Next case, this coinus deformity, childhood poliomyelitis. We did gradually correction after removal. This woman, after girl about 19 years old, after a road traffic accident with big defect of leg bones and the coinus deformity. With exposed bone, we did for her application Ilizarov and correction of the foot deformity and lengthening by distal tibia osteotomy because the proximal stock of the bone so small. There you see all leg at right side, all leg approximately